Okay, good morning. We'll be starting again the session for treatment of aneurysms, and we will be presenting to you the balloon remodeling technique, which is used to treat broad-based aneurysms. These are the conflict of interest I have. So when you have to deal with coiling of aneurysm, you have to take in account the size of the neck. And of course, if you have a small neck, it allows to keep the coils inside the sac of the aneurysm. If you have a large neck, for sure the coils will not remain inside the sac, and you will have a protrusion within the parent vessel. So the wide neck aneurysm were considered at the beginning of the year 90 to be contraindication for the endovascular treatment using coils. Because of his experience to use balloon for treating aneurysm, Jacques Moret, who was my master, had the idea to use a balloon, and the balloon was inflated in the vessel to provide a constraint within the mesh of the coil. And the idea was that when deflating so you had to inflate the balloon during the placement of the coils. And when you were deflating the balloon, the coil were remaining inside the sac of the aneurysm. So when Jacques Moret presented this work at the European Society of Neuroradiology in 1993, everybody was claiming that he was lying and that the coil, they cannot remain inside the sac of the aneurysm. So the only answer he had at that time was that he has been doing 150 aneurysms using this technique, and he was unable to explain why the coil were remaining inside, but for sure this was the result. Nowadays we completely understand how it works, and you have to apply a very specific technique to use balloon to maintain coils. And this, of course, has been published a few years after. There were two papers, one in French language and one in English language. For 20 years, we always use the same balloon. It's a silicone balloon on the wire. It has a shape of a sausage, and it is a compliant balloon. So you have several companies which are delivering such balloons, and nowadays you can deliver the balloon within the same guiding catheter as for the catheter being used for coiling. In the past, you had to use two different guiding catheters. So this is one of the first patients that was treated by Jacques Moret, and you see that it's a carotid siphon aneurysm, and for sure there is no neck. And when you place the coils, they are always going inside the parent vessel. So a balloon was inflated, so this is in 1993, something like that. I was resident in the department, and you provide a constraint within the mesh of the coils, and when you deflate, you have something which looks to a reconstruction, which is the name, the remodeling technique. You remodel the wall of the vessel. It can be applied even when you have the aneurysm which is going around the circumference of the vessel. And looking at the 3D of the mesh of the coil, and you look below, you see here the groove, the footprint of the balloon. You see here the footprint of the balloon. And you see that the coils, they are going all around the circumference of the artery. So you use this kind of technique to treat broad-based aneurysm. This is a carotid siphon aneurysm. It's a small one. And you have the ophthalmic artery, which is arising from the neck of the aneurysm, as you can see on the AP and on the lateral. This is the working projection of this aneurysm. The balloon is inflated. And when you place the coils, you see on the AP that the balloon is pushing the coil inside the sac of the aneurysm. So you have to use the inflation of the balloon from the first coil. If you have a protrusion of a coil when it is detached, the balloon will never bring back the coil inside the sac of the aneurysm. This is very important. The balloon is here to provide the constraint to the basket of coils. For the same patient, this is pre-op, and this is 2.5 years after the treatment. And you see that even you have almost no neck, you can succeed to maintain the coil within the sac of the aneurysm. And because we overinflated the balloon, we preserve the patency of the ophthalmic artery. This is the 3D rendering for the same patient. So you have to be convinced that you can apply the technique to all kinds of aneurysms, even when you have absolutely no neck, even when it's a small aneurysm. And you have to be convinced of the efficiency of the technique. Even me, I'm still amazed sometimes what you can do with a balloon. This is an ACOM aneurysm fed by the right A1. There is no left A1. And this is the 3D projection. And as you can see, there is absolutely no neck. You can say that the neck is wider than the sac of the aneurysm itself. The same balloon is placed. You have to properly prepare the balloon with contrast media diluted with water. This is the marker of the balloon. The balloon is inflated, and the placement of the first coil is very important. Sometimes it may take half an hour to place the first coil. And when you deflate the balloon, the basket of the first coil should not move. If it's moving, you have to replace it. And as Jacques Moret says, 10 times you deliver the coil, 10 different shapes you will have with the coil. So if the coil doesn't fit inside the aneurysm, remove it and place it again. It's something for which you have to be patient. Most of the time, you obtain a stable basket when you have this shape, you see, with those two round structures, meaning that the coil is blocked against the wall of the aneurysm. When you have a round structure, it's never stable. So you should use a coil in order to obtain that. Usually you inflate the balloon and the catheter is placed at the level of the neck. So this is important to obtain this shape. It is important to check that when you deflate the balloon, then it is exactly when you build an arch in a building, you use a constraint to build the arch, whatever is the arch. And when you put the last stone, it is stable, you can remove the scaffolding. So this is why you should use the balloon from the very beginning. You cannot build up such an arch if you don't have the help of a scaffolding construction. When you deflate the balloon, you should not have any movement in the basket of the coil. If so, then you have to replace again. Then after, when the basket is stable, then you use small coils. You just have to fill the inner part of the basket. Of course, each time you reinflate the balloon. Usually we try to not inflate the balloon longer time than 4 to 5 minutes, which is sufficient. Just to avoid ischemic complication and to avoid thromboembolic complication. Don't ask me 4 minutes instead of 3 or 10. This is just observation. Nobody knows. So then you continue to progressively fill the basket of the aneurysm with small coils in order to have a dense packing. And this is the final result. And even you have no neck, it's possible to obtain a reconstruction of the bifurcation. So this is used mostly in emergency. Nowadays, for non-ruptured aneurysm, we would proceed in a different way, just because this kind of aneurysm is prone for a recurrence. So we mostly use remodeling technique for ruptured aneurysm. This is a small left MC aneurysm which has ruptured. This is a closer view. As you may see, there is absolutely no neck. This is the posterior view. So the balloon is placed in the lowest branch, which is having the aneurysm. It's very easy to navigate. And then you place the microcatheter within the sac of the aneurysm. This is the microcatheter. Here is the balloon inflated, and you deliver the coils. Here we are. This is the progressive filling of the aneurysm, and this is the post-op. You see that the coils, they remain inside the sac of the aneurysm. There is no protrusion in the lower branch of the bifurcation. Another example, we mostly use that in ruptured aneurysm. On the AP view, there is nothing obvious. But when you look on the 3D, you discover this ugly-looking aneurysm. There are two portions, the upper one and the lowest, two parts. Strange aspect, I have to confess. And balloon remodeling technique was used, and we were placing coils in the upper portion, and then we catheterized selectively the lowest portion of the aneurysm, as you can see here, the two mesh of coils. And this is the post-op angio, so the coils are inside the aneurysm. The ACOM is still patent. This is the 3 months follow-up, and you clearly see on the 3D that you have coils in both parts of the aneurysm. This is the comparison of the 3D before and after the treatment. Both 3D are registered together. So this is things you can do with balloon, and this is things it's difficult to achieve if you don't have balloon. Another example of ruptured aneurysm, the patient got an external shunt. This is the AP, on which you don't see, but the 3D shows you the very tiny aneurysm. For sure, it is less than 2 millimeters, the neck is larger than the sac of the aneurysm. This is the frontal, this is the posterior view. And this is the aneurysm which is responsible of the bleeding. This is the 3D aspect. So you have to succeed to place a coil within the sac of this ruptured aneurysm. So this is the working projection. This is the placement of the balloon on the roadmap and the 3D roadmap. Inflation of the balloon. You start to deploy the coil within the sac of the aneurysm. This is the coiling. This is the groove of the balloon, which is inflated. You put a second one. And this is the post-op after 3 coils. And you got a complete occlusion of the aneurysm, even you don't have any neck. This patient worsened because there was a movement in the shunt, which was seen on the expert CT. And you see that external shunts sometimes are dangerous. And you see that the external shunt was pushed a little bit too distally. And the patient bled from the external shunt. This is the wrong placement of the external shunt. However, the patient recovered, and this is the 6-month follow-up, which is a good result compared to what it was at the time of the rupture. Balloon is used for 3 purposes. The first one was shown already, is to maintain the coils. The second is to maintain the microcatheter within the sac of the aneurysm when you have a difficult angulation. And the third is to control a bleeding when you get a rupture. And this is why all the doctors in our department, they are trained to use balloons, and they always have balloons inside the patient in case they have a rupture. They feel more comfortable with the balloon being prepared inside the patient in case they have a rupture. It's a very, very efficient tool to prevent for a very severe complication, such as this one. It's an MC aneurysm, it's a ruptured aneurysm. You see that it's a small one, there is no neck. This is the bleb for the rupture. The balloon was inflated. Here it is. And at the end, you have the rupture. So the rupture at the end is not the most comfortable. And when you have such a complication, you have always to apply the same maneuver. You inflate the balloon first to stop the bleeding. Immediately, you have a huge vasospasm, so you are blind. And then you have to coil. You don't remove the coil from the subarachnoid space. And you infuse intraarterial nimodipine. And this is what you have to do. Immediately, you reverse the heparin. This is done by the anesthesiologist. Second, you continue to coil. And if you have a balloon, you inflate the balloon. If you have no balloon, you have somebody has to prepare the balloon as quick as possible. And this is why you have to be trained to quickly prepare the balloon in case you need it in emergency. So you can differentiate depending on the location. For instance, the MCA, as it was said by Francis Turgeman, you can use different kind of balloons, sausage, compliant, or round balloon, depending of the anatomy. For MCA, you have different kind of aneurysm, bifurcation at a side branch or side wall. This kind of balloon is used mostly for side wall aneurysm. This is the case, absolutely no neck. So you will be using this balloon. There are several available on the market. You inflate the balloon, you place the coil. When you deflate, you have a remodeling, and the coil, they are maintained within the sac of the aneurysm. Second example is when it's not in front of the neck. So it will be impossible to catheterize the branch. So in this situation, we use compliant balloon, for which you have to be very careful because they are dangerous, because you can have a dissection. Nevertheless, they are useful because when placed in the lower branch, you overinflate, and because it's very compliant, it will deform to provide protection of the neck on the upper branch. So this is how you can save the upper branch, which is difficult to catheterize. When you have a true bifurcation, nowadays we would be using a web, no doubt. But if not, this is an aneurysm without any neck. So you have to protect both branch, upper branch and lower branch. This is the site of the rupture. This is a close view of the aneurysm. And you may place two balloons, which requires two guiding catheters. You cannot have two balloons and a microcatheter within the same guiding catheter. But you can use two balloons. Be very careful. You have to be very strict. If you push on the syringe and you don't see the inflation of the balloon, it means that you have clot inside the balloon, so you should remove it and clean it. Because if you push on the syringe, you inflate the balloon blindly, and this is how you can get a complication with a rupture of the vessel. So each time you push on the syringe, you should be able to see the balloon. So these are the two balloons. Thanks to the protection of the balloon, you coil to get a reconstruction of this bifurcation aneurysm. For ACOM aneurysm, you should consider how you can manage. Here you have an ACOM aneurysm. You have A1 on both sides, but for sure right is larger than the left. This is anterior view. There is no neck in this aneurysm, AP and posterior view. This is the working projection. So how you can place the balloon? So the first option is to put from right A1 to right A2. But you have to keep in mind that this angulation is difficult. The second option is to come from the other side and to cross the ACOM. So we have tried the simplest one, which is this one. But due to the angulation, you see that it's almost impossible to catheterize this angulation. It's not possible. So we decided for the second option to come from the contralateral side. But as you can see, it's a small one, and there is a spasm. And we didn't succeed to catheterize the left A1. It failed. We have tried several times with different guide wire, but it was not successful. So neither this option or this option were working. So we have used the third one, which is to use a compliant balloon that you inflate to protect the neck. So this is what has been achieved. We came from the right. This is the inflation of the balloon. And thanks to the inflation of the balloons that you have here, we were able to place some coils inside. This is deflation. The mass of coil is stable. You reinflate the balloon, and you put some small coils in the middle. You deflate, nothing moves. And at the end of the procedure, this is the result. There is a small neck remnant, but it's good. It is what we have obtained to treat in emergency this aneurysm. Even for small aneurysms, this is a small, very small A1 aneurysm, ruptured. We use a balloon. This is the tip of the microcatheter. Inflation of the balloon. Once again, you should always be able to look at the balloon. If you don't see, you have to clean. And then you place very small coils. Hopefully nowadays you have very small coils, 1 millimeter in diameter and 1 centimeter in length. And when you deflate, the coil remains inside the sac of the aneurysm. Such basilar tip, we call it a Chinese hat. There is absolutely no neck. The patient was referred from another center because the patient bled twice. He bled once, it was not possible to treat. He bled the second time, and then he was referred to the department. Look at this aneurysm, it's very, very wide neck. So we have been using this double balloon technique, inflation, placement of a coil, deflation, you check that the basket doesn't move, you detach the coil, and then you fill with very small coils inside, you deflate, and this is the reconstruction of the termination of the basilar artery to occlude the very small bleb, which is responsible of the bleeding. Of course, you know to use balloon also to treat mechanically the vasospasm. So this is a ruptured ACOM aneurysm with an important vasospasm. So we have navigated the balloon. We performed the angioplasty just to give some flow, and then we treat the aneurysm. And this is the post-op. You treat the aneurysm and you treat the vasospasm at the same time. So we frequently use balloon to treat vasospasm. Branch from the sac is something you can manage as well for aneurysms. This is a MC aneurysm. It's a difficult anatomy because you have the two lenticular striate arteries which are arising from the neck of this aneurysm. So this patient was treated more than 10 years ago during the link meeting, during the live case. Honestly, today we would manage that in a different way. But at that time, we managed with balloon. This is the working projection of this view. You have to try to preserve the neck for this lenticular striate artery. And we have used a balloon which is inflated inside the sac of the aneurysm. And believe me or not, it took a long time to place the first coil. But once again, you recognize the specific shape of the basket of the coil, which is something which is stable inside the sac of the aneurysm, just to have an arch which is stable against the wall of the aneurysm. So the balloon helps you to obtain this constraint. And as far as you deflate, it remains like that. This is the angiogram. Progressively, you feel the inner part of the aneurysm. And when you do the angiogram, of course, you still have a feeling of the bottom of the aneurysm. So you bring back the catheter and you recatheterize this portion. This is what has been done. And then you obtain a complete occlusion of the aneurysm with respect of the lenticular striate artery. So this is really a reconstruction of the neck of the aneurysm, exactly as you could do with a clip. Angle attack is a concept, meaning that you could think about changing the strategy to place the balloon. And the best approach is not necessarily the most direct one. To illustrate the concept, I have chosen this aneurysm, which is an aneurysm which is ruptured at the termination of the internal carotid artery. It's pretty large. It has a very large neck, and it extends at the origin of A1 and M1. So if you are considering to treat this aneurysm, without remodeling technique, you will have a protrusion of the coil. So you may place a balloon to protect M1, but you are exposed to have a protrusion in A1, which is not a big deal. So the best would be to put the balloon in an orthogonal direction to protect the whole length of the neck. And the way to get that is to navigate from the contralateral side and to cross the ACOM with the balloon in order to place that in this way. And this is what has been achieved. You see here the balloon which is coming through the ACOM. And from the same ICA, you have the microcatheter which will be used for coiling. And you see that on the lateral view, compared to this one, you inflate the balloon and the coils, they are going all around the balloon. You progressively fill the coils and the coils, they are going all around the balloon. And when you deflate the balloon, you have really a remodeling of the circumference of the termination of the ICA. This is the result. It's not a protrusion. It is just the coils which are going in the entire portion of the bifurcation of the aneurysm. So you can navigate through the ACOM to treat PCOM aneurysm. This is a PCOM aneurysm, ruptured, as you can see. It's a very large neck. It's impossible to place the balloon in the PCOM. You see, because of the very important angulation. And you have to preserve the patency of the right posterior cerebral artery because there is no P1. So you should coil and preserve the patency of the PCOM. So the best approach is to come from the ACOM and you arrive from the upper part. And if you arrive from the upper part of the internal carotid artery, you place the balloon. These are the two markers, and this is the microcatheter which is coming here. In such a way, you protect the origin and the patency of the PCOM. This is the 2-year follow-up for this patient. You can go from the carotid artery to the basilar artery. This is another example of a ruptured aneurysm, very ugly looking. This is a close view. And as you can see, there is absolutely no neck. There is no neck. You have to treat this aneurysm. So you can use 2 balloons. But here, we've seen that there was a very important PCOM on the left side. So we decided to come from the left internal carotid artery and to place a balloon from the left to from the internal carotid artery through the PCOM. In such a way, you can place the balloon orthogonal. You see the inflation of the balloon. Thanks to the protection of the balloon, you can fill with coils. In this situation, you are very comfortable. You see the inflation of the balloon. The balloon is coming from the internal carotid artery through the PCOM to protect the basilar artery aneurysm. This is the deflation of the balloon. And this is the post-op. You have a remodeling of the termination of the basilar artery. So since we are using remodeling, everybody was wondering if it was more dangerous to use a balloon because you interrupt the blood flow to the brain and you may have ruptures of the vessel. So we were wondering about the safety and we were wondering about the anatomical results. And the answer came 10 years ago, Laurent Spelle was conducting a study in France regarding the treatment of non-ruptured aneurysm. It is the Athena study. It was studying non-ruptured aneurysm, 720 aneurysm, which were treated in many centers in France. And as you can see, you have a population of aneurysm being coiled alone, 70%, and population being treated using remodeling technique, 37. So he did compare the two groups of patients. This is the location of the aneurysm, and you see that you have a lot of MC aneurysm because they are treated in France through endovascular approach, and of course, ICA and anterior cerebral artery aneurysm. If you compare the coiling and the remodeling technique, there was no difference between the patient being treated with coiling and remodeling technique. It was not statistically different regarding overall complication rate, regarding thromboembolic complication, and regarding perioperative rupture. The morbidity and the mortality was the same in both groups, whatever was the technique being used. No statistical difference if you look at the morbimortality complication. Then after, with Christophe Cognat, Laurent Spelle was conducted the Clarity study, which came also, I don't remember, 8 or 9 years ago, which was dealing only for ruptured aneurysms. The previous one was for non-ruptured aneurysm. The Clarity study was dedicated for ruptured aneurysms. And you see that 77% of the cases were treated with coiling alone, 20% were using remodeling technique. And again, they were comparing the complication, and you see that there was a higher risk of thromboembolic complication when using coiling compared to remodeling, but no difference in intraoperative rupture for both techniques. Early rebleeding was slightly higher in remodeling technique, but it was not significant. And the global complications were not different between the two groups. This is the morbidity and the mortality comparison between coiling and remodeling. No statistical difference, and once again, it's a group of ruptured aneurysms. So this was for the safety, which has shown the important safety of balloon remodeling technique. And you have to keep in mind that balloon allows to treat aneurysms that otherwise we would not be able to treat. Looking at the anatomical results, Laurent Spelle found no difference in terms of complete occlusion, whatever was the technique. You see here coiling in blue and remodeling in red. He did a review of the literature also in 2012, which was showing mostly the same thing. And very recently, Laurent Spelle was conducted a very important study in France. It's a prospective multi-center study which was involving roughly 20 centers in France. And the aim of the study was to try to determine which factors were involved for recanalization after endovascular treatment. So between 2013 and 2015, all the aneurysms that were treated in France were collected, ruptured and non-ruptured. So it's a huge amount of population, and they were collecting all the data. Here are listed all the data to try to determine if one of those data could be responsible for a higher recurrence. And of course, it's an important database because you see that they were able to enroll finally more than 1,700 aneurysms in this study, which is up to now the largest study being conducted in the world. Among the 1,700 global population, aneurysm were treated was 1,300. 56% of the aneurysm was treated, meaning that 40% of the non-ruptured were not treated. However, you see that in France, we mostly treat ruptured aneurysms, 61%, and in the big majority, they measure less than 10 millimeters. Wide neck aneurysm is quite frequent. You see that wide neck aneurysm was found in 1/3 of the patient. So he was comparing, of course, the coiling versus remodeling in ruptured aneurysms. And you see that remodeling now is used in 42% in the cases. I told you that the previous study in France, only 20% of the ruptured cases, it was using remodeling technique. Now it's 42, meaning that everybody now is trained to the technique. Of course, if you look to unruptured aneurysm, you have less coiling and remodeling because you have more new assisted techniques such as flow diversion, stent-assisted coiling, or web. If you look at the postoperative occlusion rate between coiling and remodeling, you see that you have a complete occlusion in 56% of the coil and complete occlusion in 59%. It's almost similar. And if you take into account the adequate occlusion, which is complete plus neck remnant, you have more than 90% of adequate occlusion in both groups. So even with very ugly looking aneurysm, using balloon remodeling technique allowed to have this result, which is stable over time. This is the 12 months angiographic follow-up, coiling 53% of complete occlusion, 60% in remodeling technique, and 94% of adequate occlusion in both techniques, even with very large neck aneurysms. So to conclude, you see that balloon is a fantastic tool. It is widely used to treat ruptured aneurysm. It's a little bit confusing with coils, especially in United States. United States, the physicians are not trained to use balloons. And second, they are motivated to use expensive material. So they are using a lot of stents for ruptured aneurysm, which is, to my opinion, a bad behavior. So to conclude, please prefer using balloon remodeling technique rather than stent in acute ruptured aneurysms. If you consider those ruptured aneurysms with a large neck, remodeling technique is a very efficient technique. And you can treat almost all aneurysms. There is absolutely no aneurysm you could not treat with this technique. And this has been shown by all the studies. There is no significant differences between balloon remodeling technique and conventional coiling group in terms of long-term angiographic follow-up, in terms of perioperative complication. Thank you very much.